Hi, my name is Susan Miller, and I'm clinical faculty at the Orlando Regional Medical Center Emergency Medicine Residency Program, and I will be presenting my SAEM 2020 Lightning Oral Presentation on significant gender differences in blood product transfusion for traumatic hemorrhage. This presentation was with the help of Dr. Linda Papa and Dr. Olivia Munizza, who is an upcoming chief resident. As always, I have no disclosures. So why do we care about this? Hemorrhage remains the leading cause of mortality from trauma, and major resuscitative measures, including quick transport times, massive transfusion protocols, and early operative repair, have been the focus in treatment of traumatic hemorrhage in recent years. There have been some established differences between gender and traumatic outcomes, most recently a paper published in 2019 with some possible protective effects of estrogen on mortality due to trauma. This study also highlighted differences such as ICU admissions. However, to date, there have not been any robust studies looking at gender differences in hemorrhage or rates of transfusion due to hemorrhage. Most of the previous studies are looking at elective surgical procedures, not traumatic, with some pretty mixed results. Some are reporting some higher incidences of blood product transfusion in females, while others are reporting the opposite. So this is a cross-sectional study based on a trauma registry data set from our Level 1 Trauma Center between the years of 2013 and 2017. ORMC is a large urban tertiary receiving hospital and trauma center with about 80,000 patients per year and 1,500 trauma patients annually. Our study population was 16 years or older, trauma patients with pre-hospital vital signs indicative of significant hemorrhage, so systolic blood pressure less than 90, heart rate greater than 110, or both. In the state of Florida, the adult trauma patient population is age 16 years or older as defined by state statute. Our main outcome was looking at blood product transfusion differences between genders and trauma patients within 24 hours of the inciting trauma. We had a little over 13,500 patients, in which 34% of them were women and 66% of them were men. Our mean age was 48 years old, and our mean ISS injury severity score was 10. Of the female cohort was a bit older. Mean age was 54 versus 44 in the male patients, with a lower ISS score in females, 9.5 versus 10.6. These female patients also had a higher incidence of blunt trauma, 94% versus 80%, and had a lower rate of trauma alert activation. So as you can see here, the mean number of blood product transfusion over 24 hours in female versus male patients was higher in males across the board. So with PRBCs, it was 1.5 versus 1.2, and this was not statistically significant. Both plasma and platelets were statistically significant, with plasma respectively 0.9 versus 0.5 and platelets 0.22 versus 0.12. The odds of receiving a mass transfusion protocol, this is greater than 10 blood product units, was in females was 0.48, and for males it was 2.11. So interestingly, the adjusted odds ratio of receiving a blood product transfusion within 4 hours of presentation was significantly higher in higher ISS, male gender, and younger age. But when you moved over to 24 hours, you lost the significance of the male gender. So when you compare the different age cohorts, the younger and middle and then older age cohorts, the younger and middle were not statistically significant between the genders. However, once you reached grades greater than age 60, you did have statistically significant differences between PRBCs, plasma, and platelets at both 4 and 24 hours. And you see this here as well. So females had a lower likelihood of getting transfused even when the analysis controlled for both injury severity and age, not significant at 24 hours. So in conclusion, compared to their male counterparts, female trauma patients are less likely to receive blood products, even after adjusting for injury severity. However, they are more likely to survive hospital admission and discharge. There's really no hard evidence to conclude why female trauma patients receive less blood product transfusion, whether it's based on implicit bias in the trauma bay versus presenting vital signs versus coagulopathy differences from hormonal effects. It's hard to know. Definitely further studies are needed, and possible implications from this based on those further studies are gender-specific transfusion protocols, which folks are already talking about in the more elective surgical procedure. If you have any questions, please don't hesitate to reach out to any of us, and we look forward to hearing from you. Thank you.